Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect welcoming you all for today's webinar, Infertility, organized by TNFOG Marathon CME. So let us start the webinar with Tamil Taiwan.
Right.
Lamp lighting. It's my privilege to introduce the moderators of today's webinar, Dr. Gayatri and Ma'am. Ma'am is consultant at Shamla Nursing Home Trichy and executive member of Triox. I welcome you, Ma'am. And it's my honor to introduce Dr. T. Radhika Gauri, Ma'am. Ma'am is specialist consultant in OBG and clinical lead at ESIC Hospital, Tirunelveli. And I welcome you, Ma'am, and I hand over the session to you.
Thank you, Sahiti. I take this opportunity to greet all of the faculties and the delegates. A very happy new year, and this is the first session. I thank Dr. Sampath ma'am for giving me the opportunity to be in this session. And I welcome Dr. Sampath ma'am to bless us with a few words. Dr. Sampath ma'am is our professor and HOD of Sri Muthukumaran Medical College Hospital. She's a FOGC Vice President in 2022, and she's currently the candidate for the
Radhika?
FOGC President as well. Yes, ma'am.
We'll start.
Senate member. Ma'am.
Yes, sir. Thank you, Radhika.
Thank you, ma'am.
I welcome you all, the faculties, delegates, and our chief guest, Dr. Sadhana Madam, for this Marathon CME, which has been conducted for the past 3 years. And this Marathon CME is having the 3 sessions, the first session being the Yuva, and they will deliver the talks for 12 minutes, and the judge will ask for 3 minutes. The same judge for all the programs, and the final best person will be awarded in the annual conference as Yuva orator. And the second session will be the update. We have the theme of a single topic. Today's our theme is infertility. The update being delivered by Dr. Kalpana, and we have the panel. That panel being moderated by Dr. Vani Pujari and Aruna Ashok, and with wonderful panelists. Now I welcome you all for this scientific session. Without wasting the time, we'll start the program. Sahiti, Madam on the CV Pudu. I welcome Dr. Sadhana Gupta, Madam. Sadhana Gupta, Madam is my best friend, and we both got the ICOG Best Governing Council Award. And Madam is the ICOG Vice Chair 2026, ICOG Chairperson in 2028. And Madam is Director and Senior Consultant in Gorakhpur, and Trustee Jeevan Jyoti Trust and Paramedical Institute of Gorakhpur. and she was president of Gorakhpur and ISOPAB, Foxy vice president, Foxy representative to SAFOG in 21, Foxy Safe Motherhood Committee 2011 to 2014, and she got the Best Committee Award, co-chair of SAFOG NCD Committee, Foxy vice president in 2016, and the founder president of North India Gynec Forum in 2022 to 25, and chair UP ISA 2014, and madam has many awards and academic and scientific awards. We welcome you, madam. We need to wish our webinar. Sadhana, madam.
So thank you TNFOG, thank you Dr. Sampath and all the coordinators, and I think it is my second or third presence in TNFOG's Marathon CME, and it has been beautifully crafted. So first of all, wishing you everyone Happy New Year, Happy Makar Sankranti, Happy Pongal, which is coming ahead, and may we are blessed with all peace and prosperity, and all the thing. The world is very turbulent, very violent today, and we need all the spirituality and all the blessings from the divine so that our world remain peaceful. So with these wishes, and the first thing first, so my first wishes, best wishes to very old friend, Dr. Sampath. I think we have grown together. We have been like what professional body working gives you. It's not a 1 or 2 or 3 year post. It gives you lifetime friends and the lifetime association with very good people. So that is the actually secret of what we get in working very hard with professional body work. And my all best wishes to Dr. Sampath Kumari. She has been always very, very hardworking, very ground to earth. And I think this is time that at the head of professional body, we get very, very simple and the grounded people. So all the best, Sampath. And
Thank you, madam.
the second thing about program. So this is a very appreciative a step that you are giving, because I have been in I think second or third time that the first
madam.
Speakers are young, and that is the way how we groom our young generation, and how we get them ready for the future as a future speaker and the future worker. And there are always judges and the seniors to guide them. And hearty congratulations for this concept. And the topics infertility is something which somehow it has been associated, it is being associated with sometime easy money and the glamour and something. But myself working in infertility, like from basic to advanced to very advanced, it is my real experience, especially to young generation, that it is one of the most humbling field, where you get so many challenges. You treat on your intuition, it goes well. You treat on many technology, very costly, and you are nowhere. And it is a very something, people think that it is a commercial area. It is a gray area of our field. But actually every OB/GYN who is in this field deeply, especially who are having their own practice and not only IVF center, they know how strong is emotional bond, and with every success and with every failure, how we are being elevated, inspired, and how we are again on the thought process that what went wrong and we could not do anything. So this is something just I wish to share, that the people think that it is very easy to go into this field, but it is something we have to be very ready for a very challenging field. So the topics are wonderful: follicular study, male infertility, basic, and yet it need a very sharp precision, very sharp observation. Kalpana is going to speak on surrogacy, which is in the doldrum after India being a hub for the surrogacy, and somehow excess of everything goes wrong always. And this is the phase where we are facing with. I hope that Kalpana is the best person to speak on that. And IUI, which is again what we say, it is a poor man's IVF. It may be gynecologist, it may be for the patient. So but if it is done very, very precisely in a well-selected case, in a very careful manner, it has a important place in the total infertility management. So wonderful crafting of program. All the speakers and the moderators are Dr. Vani and Dr. Aruna. I think we have a galaxy of panel, and always this discussion we get few tips, which in infertility we want every time a few tips that what can we can like break some block. So hearty congratulations. Thank you, Sampath. Thank you all the coordinator for inviting me here. It's always great, and Sampath has been just few days ago in our own city, and hope you had darshan of Gorakhnath ji.
Yes,
You
madam.
get
Wonderful
blessings.
darshan.
So, so this is great that to have the friend at our own city, and it is great to be in TNFOG again virtually. So thank you very much, and all the best.
Thank you, madam. Thank you. As madam was telling, Sadhana madam was, we are calling her for the second time only, not third time, madam. We will call you again third time. That is after. Anyway, thank you so much, madam. We will go with for such a wonderful blessings. We'll go with the scientific session. I hand over the mic to Dr. Radhika. See, I went to Gorakhpur and madam was what to tell. She told you can get the blessings from the Gorakhnath, and I got the blessings from Gorakhnath and all the people from Gorakhpur, and I wish everything will go smooth. Thank you, Sadhana madam. Still, madam is having the coat. It is very cold. Gorakhpur is very, very cold. Okay. Thank you, madam. Radhika, can you introduce the judges?
Yes, sir. Thank you, madam.
Yes.
Now, I invite Dr. T.
Illa Radhika, Deliva illa. I will introduce. Dr. Shanti. Dr. Shanti is the professor in Savita Medical College. Radhika, I will introduce. She was disturbing. So she is trained in publications 25 plus, and her field of interest is endoscopy, high risk pregnancy, and examiner in Tamil Nadu and other states. Next slide, please, Dr. Kartika Prabhu. She is the professor from SRM Medical College, Katangalatur, and special interest is high risk pregnancy. She has many awards, and Asha Bakshi Award for annual conference in 2026 AICC RCOG. Best Paper Award in UFOXY and the DIPSY 2011 and 2013, Gold Medal Research Day SRM 2020. She has done the A.L. Modalia Traveling Fellowship. Now she is doing her PhD and faculty in many conferences and credentiated IMS Menopause Practitioner CAMP exams, I think. Welcome, Dr. Kartika and Dr. Shanti, who has been the constant judges for the past 1 year, for the past 2 years. Thank you, Dr. Shanti and Dr. Kartika. Can you introduce Dr. Nitya, Dr. Shanti or Kartika?
Dr. Nitya is a consultant in A4 Fertility Center, and she's previously worked as professor in Ramachandra. She has delivered Dr. Jayashree Gajraj Endowment Oration at Yuva Oxy 2023, and she also got a lot of awards. She is executive committee member of Tapizar 2025, and she is a member of Oxy, IZAR, Tapizar, IFS. Her special interest is infertility, high-risk obstetrics, and gynec endoscopy. Dr. Nitya will be talking about follicular monitoring. Over to you, Nitya.
Yes, ma'am. Ma'am, yeah. Can I? Yeah.
Yes, Nitya.
Yes, ma'am. I'll just share the screen. Yeah, is my screen visible, ma'am?
Yes.
Yes, okay, I'll go ahead. Thank you, Sampath ma'am and TNFOG for giving me this opportunity. So I have a quick 12 minutes to talk about the follicular monitoring, which is a very basic, but yet it is a fundamentally most important step of any infertility treatment. Now, coming to the learning objectives of my talk today, we're going to be talking about the baseline ultrasound parameters, how to predict the ovarian response, and how to monitor the follicles. Now, the AFC or the antral follicular count and the implications, we have 3 categories, which is the normal AFC count, the low AFC, and the high. So there is no particular cutoff or any guidelines which says this is the cutoff for a normal AFC. So we range anywhere between 8 to 15 as a normal reserve. Anything less than that is a low reserve, and anything higher than 20 is taken as a higher reserve. So how do we do the training? So there should be a fixed ultrasound protocol summaries should be there for each of the hospital, and use a transvaginal probe always for a follicular monitoring. Ideally between day 2 to day 5 of the cycle should be the baseline scan, and a minimum of 20 to 40 supervised examinations are recommended for us to have a better accuracy. Now, so there is AFC versus AMH. So when we see AFC is the most reliable predictor compared to all the age groups, be it young or old, AFC comes first. There's always a debate between which is better for an ovarian reserve. Is it the AFC or the AMH? But AMH is less reflective of the current follicular pool. So it can differ this month. So exactly the pool for this month is the one that is going to give us. So that's the crop that we are going to be getting. So AFC at every follicle, every month is going to be different. It will have some variations, so we will have to check the AFC, which is mandatory, and combining AFC with AMH is going to be giving you a similar predictive outcomes. And so AFC remains the key parameter. AFC in special considerations, especially in cases of endometriosis, or when there is a discrepancy between AMH and AFC, we will take the AMH. And in some cases, when there are clinical recommendations are there, priority for AFCs should be given. So how do we do the folliculometry is the scanning of both the ovaries should be done in multiple planes to accurately count the follicles. It should be between 2 to 9 mm on a baseline scan, and we'll have to sum both the ovaries to get the total follicular count. So you have to adjust the gain and the contrast to get to visualize the follicles. And why we have to adjust this is that there should be a difference between the stroma and the fluid-filled follicle. So the interpretation is whenever there is a lower count, it means the reserve is less. When there is a higher AFC, it means the count is more. So a little more adding to the folliculometry is the ovarian volume. We will see. We will know about the stromal follicular monitoring and also the follicular Doppler and the outcomes. So how do we see the ovarian volume measurements? So ovarian volume measurements can be done on a 3D machines where it can be automated. But if it is not there on a 2D, 3 diameters have to be taken from outer border to outer border. So the length, width, and the height, all three will be taken into 0.523 will give us the volume. A volume of more than 3 ml for a 3 cc on the day of trigger is considered to be a good follicle volume. And as we know, as there is age-related changes in the ovarian vascularization, as age increases, the blood flow decreases. Now coming to proper how a follicle has to be monitored. First is on a baseline scan between day 2 or day 3. Follicles should be between 2 to 9 mm. There should be no residual corpus luteum or any cyst. And ovarian reserve should be assessed by AFC, and the ovarian volume has to be assessed where we take the cutoff of 10, and the endometrium should be thin. And we can do a stromal Doppler. So the first 4 points is being usually it is being done. So doing a stromal Doppler and RI has become not mandatory, but it is of a lot of use when we start doing the stromal Doppler, RI, and PSV on the baseline scan itself for us to decide the dosage of how much gonadotropins to be given in that cycle for that particular patient. Yeah. So suppose in a patient with PCOS, so that patient has androgen excess, the stroma is going to be very dense. In that case, there's going to be increased stromal blood flow. So in these patients, you can predict OHSS, and we will be giving a lower dose for these patients. So this is how the stroma is seen. And then we will go for the thicker, straight intrastromal vessels. We will avoid the vessels at the hilum. We will place a small gate, 1 to 2 mm. Choose the most consistent and the more non-tortuous vessels, and the PSV and RA can be automated or can be measured manually also. A PSV of more than 10 is considered to be good. And whenever there is a, so how we decide is when the RI is less than 0.5 and the PSV is more than 10, they are hyperresponders. A normal responder will have a PSV between 5 to 10 and a RI of 0.6 to 0.7. A poor responders will have PSV of less than 5 and an RI of more than 0.7, which means in a patient, if the PSV is increasing, it means there is a good blood flow and their response will be very good. So follicle with the highest FSH sensitivity will respond better to the rising FSH, and as the follicle is growing, estrogen is going to be produced from the follicle, and the follicle will be continuously growing. When the estrogen becomes adequate, this will suppress the FSH. All the other follicles will undergo atresia because of this. Now, the final maturation is by the LH that will act on the granulosa cells of the dominant follicles in the late follicular phase. Now, when this estrogen is increased, it will have an feedback mechanism on the LH, which will cause the LH surge for the ovulation to occur. So, for our follicular characteristics, 3 things are important: the size, the shape, and the thickness, which we're going to discuss in detail now. How to diagnose a dominant follicle? Before the day 5 of the cycle, by day 5 of the cycle, selection and dominance will start to occur, and this is why we say anyone starting a follicular study is between day 2 or day 5 of the cycle because of the dominance. A recruited follicle will start to pull the blood vessels towards it immediately after the dominance is selected. So more than 10 mm, we call it as a dominant follicle. It grows at 2 to 3 mm per day. Ovulation is between 18 to 24 mm. Estrogen starts raising by day 5 and it is responsible for the vascularity. 2 days prior to ovulation, the follicular resistance will fall, which means there is going to be more blood supply, and you can see a cervical mucus, which will indicate a good estrogen reserve. So the key ultrasound signs before ovulation is you can see there is a sonolucent halo which will be present around the follicle, which will be 24 hours prior to the ovulation. You can see a cumulus like shadow, which will be 36 hours prior to the ovulation. And you can also see the perifollicular vascularity and the RA and PSV, which I will be telling now. How do we calculate the follicular PSV? It is something similar to how it is done for the stromal RI and PSV. It is just that the follicle wall, we have to place the gate and get it automated or measured. We will get the PSV and RI. So the 2 numbers that we have to remember is PSV of more than 10 and an RI of less than 0.5. So we can wait until each follicle gets this number for us to give the trigger, so that we will be sure that that particular follicle has got the maturity. So also there is something, so in case we are not able to measure all of these, at least a minimum of a color Doppler can be applied on the follicular wall. We will see if it is less than 25% or 50% or 75% or 100%. So there are 4 gradings. So we should wait at least for it to become 75. So the 2 numbers that I told was the RI of less than 0.5 and a PSV of more than 10. So the perifollicular vascularity, which I just said, so the vascularity will indicate that the follicle is viable. The measurements, the Doppler will reflect the oocyte quality. Low vascularity means that there is a potential fertility issue in these patients. So the newer trending one is the 3D power Doppler, where the same thing can be done and the follicular volume can be calculated by just using a 3D. And the cumulus oophorus appearance, which we saw on the 2D, which will not be there for all the patients, you can see it on a 3D. So there's a small dip in here. And also the power Doppler, like how we saw the PSV and RI, we can have a vascularity index, flow index, or a vascularization flow index. So what is vascularization index? Is the percentage of the blood vessels on the wall. What is the flow index? What is the intensity of the blood flow in that wall? So high vascularity index means more blood vessels are there. High FI means stronger and faster blood vessels are there. So what is VFI? It is a combination of these two. So when you calculate, you can see a beautiful picture like this, which will tell us about the vascularity of the follicle. So these also have some measurements, a VI of more than 5, FI of more than 35, and VFI of more than 2. So this will tell us about the maturity. So there is also a uterine artery resistance, which can be seen during the follicular metry. Not talking much in detail about it. So how do we decide on the trigger? Make sure there's a perifollicular halo, measure the PSV and RI. If 3D power Doppler is available, please do it. When the PSV is more, then you can plan a single IUI immediately the next day, because it means that the vascularity is very good, that the egg can rupture early. So if the PSV is less, then plan your IUI after 36 hours. If your PSV is anywhere between 15 to 25, a double IUI can be planned. The RI will be very less and the PSV will be very good. In case we don't get a good PSV and RI, it means that there can be a LUF also. So endometrium, not to forget about the endometrium while doing the follicular scan. In an early proliferative phase, it's going to be thin. In the late proliferative phase, we will see a beautiful triple line. And in the secretory phase, after the progesterones are released, so the endometrium becomes like this, which is the progesteronized endometrium. And endometrial Dopplers, not to forget on the Dopplers for the endometrium, grade 1, 2, 3, and 4. So these are the zones where the vascularity is reaching. So this can also be measured. So and the 3D also has a good value of, we are doing a Sono AVC, which automatically you just have to take a sweep and it is going to be measuring each of the follicles, not just in 2 dimensions. It is going to be taking 3 dimensions. Hence, it will be able to give us the volume of each of the follicles, and it is being done on the day of trigger so that we can decide the trigger on not just the measurements, can also be done with the follicular count of each follicles. It is of very good use, especially when there are more than 15 follicles in IVF patients. 3D Sono AVC is preferred for greater accuracy. So this is how the measurements are being given, x-axis, y and z, and this is the mean diameter and this is the volume. So it is given for each of the follicles. So this is called as a 3D vocal. So the summary of which is the follicles between 16 to 18 mm and the morphology with a thin wall, no internal echoes. There should be a halo, vascularity of more than 3/4 of the circumference with 75%, RI of less than 0.5, PSP of more than 10, a volume of more than 3 cc per follicle. And if you could find a cumulus, it is great. And if you do a power Doppler, it can tell us about the vascularity. And in the endometrium, anywhere between 8 to 10 mm, have a good grade A to B zone and the RA of less than 0.5, and the volume of the endometrium can also be measured. So the advanced methods are going to be all automated. There is studies on artificial intelligence in follicular assessment. There's something called as an unexplainable AI, which will analyze the follicle on the day of trigger and tell us which follicle is going to give the mature oocyte, and it will give us the follicles accordingly, which is more for IVF patients. Self-monitoring at home. There is studies on wearables which the patient can wear, and they can have the follicular, they don't have to come for the follicular scans. They will just send us the reports. So there are so many more advances in the future directions, which is going to be, I mean, we need more studies on it. However, on folliculometry, what we have done so far is the 3D power Doppler and the Sono AVC. Thank you so much.
Good presentation, Nitya.
Thank you.
So you have just emphasized the importance of just not doing a follicular size measurement, and endometrial thickness alone is not sufficient.
Yes,
So you require a Doppler.
Yes, ma'am.
To have a better success rate.
Yes, ma'am.
Can you
do you recommend Doppler for everyone, for all the patients?
Ma'am, now all of the ultrasound machines at least have they have the basic Doppler settings, ma'am. So all patients, if the facility is available, the Doppler settings for just the peak systolic velocity and the RI can be used, and it increases the pregnancy rates to a drastic good amount, even for an IUI cycle. So using a PSRI on the day of trigger at least should be able to give us a clarity on the maturity of the follicle.
Thank you, Dr. Nitya. So I have a doubt. Like,
Yes.
how is it going to translate into the outcome? Like, based on that, can you differ IUI or something like that?
Ma'am, if the RI and the PSV is less, all that we have to do is just to wait 1 or 2 days extra and keep measuring it. And we can see if it is increasing, it is on the increasing trend or not. So if it is on the increasing, usually it is on the increasing trend, but we usually take the measurements anywhere between 18 to 22 mm for the trigger.
Yeah.
So the follicles on vascularization, it says it is not just the size that is needed, it is the vascularization that is important for the maturity of the follicle. So we have to wait 1 or 2 days extra to get the good vascularity and then give the trigger. So when we do this, we are indirectly talking about the maturity of the follicle, which can give a better pregnancy results. And we have a study on this, which is going to be having a publication soon, ma'am, which I did present it in the ISOG conference in Bangalore, and did win a prize on that. So it tells about how the pregnancy rates are increased with just the Dopplers.
Yeah, that should be a good one. So we are awaiting your publications to
Thank
see.
you, ma'am. Thank you.
Okay, thank you, Pa. Okay, following Dr. Nitya, we have Dr. G. Kavipriya, MS DNBOG. She is a consultant at Divya Hospital at Tirupur, and she has completed her MBBS at Kilpack Medical College and MS at Stanley Medical College. And she has a clinical focus area on antenatal, both the normal and also high-risk pregnancy management, and gynec disorders and women health. And she's a member in TIOGS, that is Tirupur Obstetrics and Gynec Society. So over to you, Dr. Kavipriya, on male infertility.
Thank you, ma'am. Are my slides visible, ma'am?
Yes, ma'am.
Yes, visible.
Yes, ma'am. Good evening, everyone. I thank Dr. Sampath Kumari, madam, TNFOG secretary, and Dr. Pungodi Selvaraj, madam, TIOX president, for giving me this opportunity to be a part of the session. So now I'm going to discuss about male infertility. So, as we all know, infertility is a failure to achieve pregnancy within 1 year of unprotected sexual intercourse, and it can be either primary or secondary infertility. So, the prevalence of infertility is female factors, they contribute to around 40 to 55% of cases, and male factors, they contribute around 30%, and both male and female, they contribute around 10 to 20%, and unexplained accounts for about 10 to 15% of cases. So before going to the male infertility, just a brief idea about spermatogenesis. The spermatogenesis occurs in the seminiferous tubules in the testes, and spermatogonia, they get developed during the intrauterine age. They gets converted into a primary spermatozoid, which in turns undergo meiosis 1 and 2 to form spermatid, and which in turns converts into spermatozoa. So it takes around 72 days for the complete development of a sperm, and the entire process, along with the transit, it takes around 3 months. And this is structure of a normal sperm with the head portion containing the nucleus and the chromosome covering, and the middle piece with the mitochondria and the flagella. So the endocrine control of spermatogenesis, it is a hypothalamus, pituitary, and the testicular axis. The GnRH from the hypothalamus will act on the anterior pituitary, causing the release of FSH and LH. LH, it act on the Leydig cells, which in turn causes the development of release of testosterone, which helps in spermatogenesis. And FSH will act on the Sertoli cells, which release inhibin along with that androgen binding protein and Mullerian inhibiting hormone. Testosterone in turns has negative feedback mechanism on both anterior as well as hypothalamus. Inhibin in turns inhibits FSH. So the factors contributing to male infertility includes disorders in spermatogenesis for about 50%, and obstruction in the efferent ducts is around 30%, and disorders in sperm motility is 15%, and unexplained is 5 to 15%. So the etiological classification of male infertility, the genetic causes includes abnormal Y chromosome or 47XXY in case of Klinefelters, or mutation in the short arm or long arm of the Y chromosome. And disorders in spermatogenesis, they can be pre-testicular, testicular, and post-testicular. The pre-testicular mainly includes hormonal. There is the hypothalamic disorders or Kallmann syndrome. Ma'am? Kallmann syndrome's GnRH deficiency, and pituitary secretion of FSH and LH, hyperprolactinemia leading to decreased libido, or hypothyroidism, adrenal gland disorders, and diabetes. So coming on to primary testicular disorders, which may be idiopathic or presence of varicocele or absent germ cells, which in turn lead to decrease in the spermatogenesis, or chromosomal defects in Klinefelters, or cryptorchidism, or environmental factors like exposure to drugs, like calcium channel blockers or anticonvulsants, antihypotensives, exposure to radiation, or orchitis may be due to traumatic or infective like mumps, tuberculosis, and gonorrhea, or chronic systemic illness and immunological disorders. So the post-testicular is duct obstruction, so the congenital absence of bilateral vas deferens, or inflammatory blockage due to gonococcal and tubercular infections, or surgical trauma or Young syndrome. Other causes includes E. coli, staphylococci, chlamydia infections, and mycoplasma genitalis. Other accessory gland disorders like prostatitis may also causes duct obstruction, leading to abnormal semen analysis. So the disorders of sperm and vesicular fluid, presence of anti-sperm antibodies in the cervical mucus, or due to low fructose levels in the seminal plasma, or sperm acrosome defect, or zona pellucida binding and penetration defects, and oocyte fusion defects. Sexual dysfunctions includes decreased libido or hypospadias, premature and retrograde ejaculation. And psychological and environmental factors like smoking, alcohol consumption, and substance abuse, and obesity is most important factor causing the peripheral conversion of androgen to estrogen and affecting fertility and chronic evaluation involves history taking, examination, and investigations. So in history taking, age of the male partner is important, and duration of marriage, and duration of infertility, and any past conception with previous or present marriage, and previous fertility investigations and treatment history has to be evaluated, and coital history like frequency of the intercourse, and regarding the erectile function and the ejaculation and any lubricant usage must be asked. Medical histories, diabetes, hypertension, or any respiratory tract disorders, or liver disorders and neurological disorders, any history of high fever during the past 6 months, and any medication usage and the duration of the drug, and urinary tract infections and sexually transmitted diseases, and surgical history, past history, surgical history of any vasectomy or testicular surgeries, and adjacent organ surgeries like inguinal hernia repair or prostatectomy or bladder neck operations, and urethral strictures or penile surgeries for hypospadias or epispadias must be asked. And developmental and childhood history includes the onset of puberty and sexual development, and any history of scrotal injury or testicular torsion in childhood, history of any mumps or other viral illnesses, and any treatment for undescended testes, and occupational history like exposure to heat, toxins, or carcinogenic dyes has to be asked, and smoking, alcohol, and substance abuse history must be important, and any family history of infertility or any metabolic syndromes or recurrent pregnancy losses and endocrine disorders. So coming on to examination, it includes general examination and local examination. General involves height, weight, and BMI must be checked, and secondary sexual characters and thyroid enlargement and blood pressure must be evaluated. And scrotal examination, it includes examination of penis and scrotum for any surgical scars, and the testicular volume, which is normal, is about 15 to 13 ml with average of 18, and testicular volume of less than 6 ml will be seen in atrophic testis, and we have to look for any presence of varicoceles. And abdominal examination, presence of scars in the inguinal area, they may indicate inguinal surgery or treatment of undescended testes. So investigations, general investigations like a complete blood count, fasting and postprandial sugars, urea, creatinine, and viral markers must be done. Apart from that, semen analysis, hormonal assays, and immunological tests, and patency of VAS and genetic testing. So the semen analysis, we mainly look for the sperm count, sperm morphology, and sperm motility. And this is the normal spermogram. The WHO reference limit of semen analysis is semen volume. It should be more than 1.4 ml, and concentration should be more than or equal to 16 million, and total sperm count should be more than or equal to 39 million, and total motility should be more than or equal to 42% with progressive motility of more than 30%, and normal viable sperm should be more than or equal to 54%, and normal forms should be more than 4% with absent of leukocytes. So the sperm count is most important in semen analysis, and is a normal sperm. With oligozoospermia is a reduction in the sperm count, and cryptozoospermia, azoospermia, and teratozoospermia is abnormal morphology, and asthenozoospermia is abnormal motility of the sperms, and OAT, that's oligoasthenoteratozoospermia, and the last one is necrospermia with no live spermatozoa. And in case of azoospermia, if there's no sperm in the semen sample, we have to centrifuge the semen sample at 2500 RPM for about 5 to 10 minutes, and we have to examine the pellet formed for any presence of sperm. If there is any sperm is found in the pellet, then it is cryptozoospermia. If there is no sperm found even after centrifugation, then we need to repeat the semen analysis after 1 month before giving a final report. So next is hormonal profile. TSH, prolactin, FSH, LH, and estriol and serum testosterone levels are checked. So in case of increased FSH and increased LH with low testosterone, it indicates testicular failure, or increased or normal FSH with normal LH and normal testosterone is abnormality in spermatogenesis, and decreased FSH and decreased LH with low testosterone, it indicates hypogonadotrophic hypogonadism. So other specialized tests includes detection of sperm autoantibodies or sperm penetration assay, human zona binding assays, and CASA, that's computer assisted sperm analysis, or acrosome reactions, and biochemical test, and sperm chromatin structure, this DNA fragmentation index. So genetic evaluation, it includes karyotyping or Y chromosome microdeletions, and CFTR gene mutation to rule out CABVD, and DNA fragmentation index. So this is the DNA fragmentation index, a sperm chromatin dispersion test. The normal, it includes the presence of large and the medium halos around the sperm head, and if the fragmented, which shows a small halo or either no halos. And other investigations, scrotal ultrasound with Dopplers, and transrectal ultrasound and transabdominal ultrasound to rule out renal anomalies, and at last testicular biopsies. So management, it's medical, surgical, and reproductive techniques. So the medical management, In case of hypogonadotrophic hypogonadism, we can go with either HCG or exogenous testosterone. For the non-responders, both HCG and HMG or pure FSH can be tried. And in case of hyperprolactinemia, dopamine agonists are given. And for normogonadotrophic hypogonadism, that's in case of severe oligospermia that is less than 5 million or with low serum testosterone levels, aromatase inhibitors can be tried. In case of hypergonadotrophic hypogonadism, either IUI with donor sperm or IVF with ICSI can be done. For erectile dysfunction, sildenafil can be given. For retrograde ejaculation, symptomatics and ephedrine can be given, and antibiotics for local infections. So this is a primary pathologies of the male reproductive system. The environmental factors like drugs, smoking, and pollution, they cause oxidative stress, and other systemic pathologies like diabetes or malignancies and other systemic infections also causes oxidative stress to the sperm, causing spermatozoal dysfunction leading to infertility. And these are all the adjuvants which are given like folic acid, the zinc and selenium, vitamin C and E, and arginine can also be given. And surgical management is vasoepididymostomy or vasovasostomy procedures being done, and if any varicocele, its repair has to be done, and orchipexy. And the next one is ART, in which artificial insemination is indicated in case of any chronic medical disorder in male, or severe oligozoospermia or ejaculatory failure, premature ejaculation or retrograde ejaculation, or presence of anti-sperm antibodies in the cervical mucus, or in case of unexplained infertility or HIV positive male. So the methods techniques used are either intrauterine insemination or intracervical or pericervical, and vaginal insemination can be done. And assisted reproductive techniques includes IVF along with ICSI, IVF or ICSI, and PSA, that is a percutaneous epididymal sperm aspiration, or TSH testicular sperm aspiration, or MESA, that is microsurgical epididymal sperm aspiration, or micro TSA can be done, or otherwise donor programs last resort. And the sperm retrieval techniques, it includes for non-obstructive azoospermia, TSA or micro TSA can be done for retrieval, and for obstetric azoospermia, that's MESA or PESA can be done. So thank you everyone.
Good presentation, Kavipriya. It's a big topic. You have to cover it within 12 minutes. Okay. So you mentioned about DNA fragmentation index. So which cases
Yes,
you
ma'am.
like to do genetic testing or DNA fragmentation index? Which type of male infertility?
Ma'am, if all the investigations like semen analysis and the hormone profiles are normal, since till then if the couple doesn't conceive, we can go for DNA fragmentation index even after trying in many multiple treatments for infertility. If they didn't conceive, we can go for fragmentation index, ma'am, to look for the DNA whether it is good or not by doing that chromatin density test.
Any other indication is there for DNA fragmentation index?
Mm.
Okay,
Anything
so
to do with recurrent pregnancy loss?
Yes, ma'am.
Okay. So we have always been talking about varicoceles, and so
Yes, ma'am.
what is your take? Still it is there, right?
Yes, ma'am. I can't get you, ma'am. Varicocele.
Yeah, varicocelectomy.
Yes, ma'am. Varicocele repair must be done before like starting any mode of treatment, ma'am. Since it interferes with the vascular supply, interferes with the spermatogenesis, the repair has to be done.
So maybe it is not necessary in all cases. Okay, what is the role of letrozole?
Ma'am, in case of low testosterone levels, or in case of severe oligozoospermia, letrozole can be tried for inducing the sperm dysfunctions, ma'am. It unlike
Where exactly it is used, especially in obese males, right?
okay, ma'am.
So that
part you could have, you could have explained, because the role of
ma'am.
lateral in females, we
Okay.
know, like, what's the
Yes,
role of
ma'am.
lateral in males. Yeah, that is there. Otherwise, it was a good presentation. So, like, it's a vast topic, I know. Yeah.
Thank you.
Okay. Thank you.
Hello, Kartika. Hello, Kartika Shanti.
Yes, ma'am.
Yes,
Over,
ma'am.
Amma.
Ma'am.
Over. Thank you, Dr. Kartika and Shanti. I thought Radhika is there. Anyway,
Thank you, madam.
thank you, Shanti and Kartika, and the speakers, Nitya and Kavi Priya. Now we will go to the next scientific session, the update by Dr. Kalpana. Kalpana, are you there?
Yes, ma'am.
Now I invite our chairperson, Dr. Pungodai. Dr. Pungodai is the gynecologist and laparoscopic surgeon and fertility consultant at Tirupur, and managing director, Divya Hospital, Bhavya Fertility Center, Tirupur, and founder president of Tirupur OG Society, which I attended, which was a wonderful program with I think more than 70 members from IMA and IAP and all other association. And Pungadai madam is the member of ISAR, FOXY, PCOS, and X-ray. Her field of interest is ART, operative laparoscopy, and hysteroscopy, high risk obstetrics. Pungadai madam, welcome. You introduce our speaker, Dr. Kalpana, who is an infertility committee chair of FOXY. Welcome, Kalpana.
Thank you, ma'am. Thank you, madam, for the nice introduction. Today we are having Dr. B. Kalpana. She is MCOT president. I couldn't see the slide clearly. She is going to talk on surrogacy update 2024. Over to you, Dr. Kalpana.
Thank you so much, ma'am. First of all, I would like to thank
Kalpana, 1 minute.
uh,
Kalpana is the course director of postdoctoral fellowship in endogynecology affiliated to MJR Medical University, co-chairperson of TNFOG, co-chairperson. She is the chairperson of Infertility Committee TNFOG, vice president of Marks, and president Madurai chapter of TAPISAR, and or secretary of Madurai Society, and she has organized the annual conference and our South Zone VP conference, which was conducted in Kodaikanal, for which she was the organizing secretary. And she is the peer reviewer of Joki and lecture in CL Jawari Symposium. And she has been invited in many national and international conferences and published 15 papers in national and international journals. And she has media awards to her credit. Kalpana, stage is yours.
thank you.
Okay, ma'am, no problem. I'm having my mobile only. I couldn't see anything.
No problem. No problem. Thank you. Thank you, Kalpana.
Thank you so much. First of all, I would like to thank TNFOG office bearers, organizers, Vidya Prabhar madam and Sampath Kumari madam. Especially Sampath Kumari madam, who had invited me for this webinar. I know Madam Sampath Kumari has been working very hard over these years, running across India and opt candidate for presidential candidate in the upcoming election, and I wish her a great success and would like to see her as FOXY president in the immediate future. And I also thank Pungodai ma'am for joining in MCOT conference and also here as a chairperson. So now the topic of discussion is surrogacy rules, recent changes. First, I would like to discuss, do we have any debate about first surrogate baby? Should we consider Lord Balram as first surrogate baby who had been transferred from the womb of Devaki to the womb of Rohini to protect him from Kamsa, or should we consider Kartigeya as first surrogate baby who
கல்பனா நீ ஷேர் பண்ணிருக்கியா எதுவும் இல்லையா
இல்ல மேடம்
சரி ஓகே ஓகே
who was born in the beds of Ganges. So, leaving about all histories, even in Bible, it is said that surrogacy is not a new thing for us. It has been practiced from the history, olden days also. Even in Bible, we could see that Sarah requested Abraham to impregnate her maid Hagar to maintain the relationship, marital relationship, and to reduce the society pressure. So obviously surrogacy can be natural by insemination in the previous years, and traditional where surrogate donates her eggs. Gestational is only egg is from someone else, and surrogate carries the baby alone. So, seeing this picture, we all know very clearly, yes, it is Louis Brown, first IVF baby born in 1976, July 25. But do we know about this couple? Obviously, we are not very familiar with this couple, Mrs. Jill, who was the first surrogate baby born to famous cardiologist Elliot and Sandra. Parents were very keen on privacy and anonymity, so it was kept confidential. So it is not known for many of us. First, coming to the need for surrogacy act. Actually, first surrogacy contract was made in 1976, but by Attorney Neil drafted this, but it was ignored by many people. So then baby M case, which came popular in 1986, actually intending couple William and Elizabeth wanted surrogate Mary Beth to carry their baby. But unfortunately, Mary's husband was included in the birth certificate as father of the child. So William has to go to court to get his rights and baby back. So then first compensation was done in 1980 for carrying a baby. Then it became a huge market, and it was like publicizing womb for rent. Then India became the hub for surrogacy, and the documentation was very poor. In 1985, it was documented only 750 cases, surrogate cases per year. So then this is in 2018, Jassy, 56-year-old female, who became the surrogate for her daughter and carried almost twin baby at the age of 56. Is there any limitation of age? And at the age of 56, there is obviously going to have more complications, medical complications in pregnancy, and maternal and neonatal safety should be considered in this case. So, considering all these options, Surrogacy Act came into the picture 25th December 2021. It is very clear that it should be altruistic surrogacy. What does it mean? It should not be a commercial surrogacy. No monetary compensation should be given to surrogate other than the real expenses needed for the surrogate mother during pregnancy and in the postpartum care. At the same time, it also tells that selling or buying of human embryo is not acceptable by giving payment. So, then initially it was said that surrogate mother should be related to intending couple or women genetically. Then there was a relaxation in the law. Even if the surrogate is not related, it is acceptable. So obviously, intending couple, the law is very particular that social surrogacy should not be the routine choice, and intending couple should have definitive medical indication, like who had undergone hysterectomy, maybe in the postpartum period, or sometimes for various other reasons, or sometimes if she doesn't have yeah, if she has got infantile uterus, or in selective cases, intending couple can opt for surrogacy. So that will be verified by local team. Intending woman, can single woman go for surrogacy is the next question. Yes, obviously she can go if she is of Indian origin, and if she is a widow or divorcee, maybe at the age of 35 to 45, she can go for surrogacy. But at the same time, it is very clear that commercial surrogacy is punishable offense, and the center should have adequate staffs, and advertising commercial surrogacy is a punishable offense nowadays. So storing human embryos for the purpose of surrogacy, or a surrogacy procedure without registration of the clinic, or conducting abortion without registration is an offense. So, what is the purpose of our surrogacy law? Obviously, it is to avoid commercialization, only altruistic surrogacy, and not for producing children for sale. So, exploitation of surrogate or exploitation of the child for prostitution is a punishable offense. So we have various boards that will verify each and every step, and the intending couple should have essentiality certificate. That means the couple is an apt couple for surrogacy, but genuinely needs surrogacy, probably because of infantile uterus, or hysterectomy procedure, doesn't have, or any other medical condition which is life-threatening, she cannot carry the baby. So all these will be verified by appropriate authority. Now district medical board, in every district we have. And also they should get for the safety of the baby, birth affidavit from first-class judicial magistrate. So surrogate cannot, after delivery, cannot demand that it is her baby. So to become, to be on the safer side, this judicial birth affidavit is also essential. For the safety of surrogate, insurance coverage for 36 months to cover pregnancy complication and postpartum complication is also mandatory. At the same time, who can become a surrogate? Surrogate should be married and having at least one child, living child, and between the ages of 25 to 35, and no medical or psychological abnormality. And at the same time, intending couple also should satisfy few rules. The male can be 26 to 55, female should be between 23 to 50, and they should not have any surviving child, either by birth or by adoption. Sometimes if the child is mentally retarded, they can now go for surrogacy. But otherwise, if these conditions are not satisfied, the intending couple cannot go for surrogacy. At the same time, before the clinic should counsel the surrogate and the intending couple about all possible side effects, and written consent should be obtained by the clinician in the presence of a lawyer, and surrogate mother has got the right to withdraw her consent at any point of time, even before embryo transfer. So the obviously the intending couple should not have a normal living child, and the number of oocytes or human embryos to be transferred for surrogate is similar to ART rules. There is no deviation from the routine rules, ART law. So now this is too late. Application everyone must have sent, and application should be sent to the National Registry, and appropriate authority comes for inspection, and then they grant the center as a registered surrogacy center, and that registration is valid for 3 years, and that certificate should be displayed in the surrogacy clinic. At the same time, appropriate authority can reject the application, but at the same time explaining the reason for rejection and giving adequate opportunity for the applicant. At the same time, if there is any breach in the regulation, appropriate authority can send show cause notice, or sometimes even without any notice, the appropriate authority can seal the clinic. So within 30 days, the appropriate authority should come will come for inspection, and if for genuine reason, if the clinic feels that the clinic can go for an appeal to the state government or central government if it is in the union territory. So we have various hierarchy of members from Health and Family Welfare Ministry, and 3 women MP from various related departments, Women and Child Welfare, and also Director General of Health Service. So all these regulations are laid by them, and state authorities, mostly Joint Director, will be the appropriate authority in many of the places. And coming to the punishment, it is really stringent regulation. Exploitation is really we have great punishment like imprisonment for a term, and sometimes fine up to 10 lakhs. It is not only registered medical practitioner. If the intending couple or intending woman breaches the law, or clinic, whichever is breaching the law, the punishment is there for them. Imprisonment for a term up to 5 years, fine 10 lakhs for the first breach, and sometimes sometimes in the second time, the punishment is more than that. And so sometimes it is non-bailable offense, so it is not an easy job, and only first class judicial magistrate will appear for this case. So surrogacy clinic should maintain the records for almost 25 years. But if there is a case against that clinic, the material should be maintained till the case gets over. So appropriate authority has got every right for inspection and getting the records from the clinic. Appropriate authority has got all the rights to search, seize, and sometimes even seal. So to conclude, so surrogacy law is a stringent law like PCP and DT. So we all should abide by the rules of our ministry, and should be very careful before before treating a patient by surrogacy. Thank you so much.
It was a wonderful presentation, Dr. Kalpana. And in 2024 February, there is an amendment. That is, we can use donor gametes also for
Yes.
surrogacy.
Yeah.
Previously it was
Yeah,
banned.
it was initially
March
whole,
23 amendment, it was banned. And now, after the Supreme Court intervened, and
yes, now it is
we
possible.
can use donor gametes.
Yes.
And whether we have to do only fresh transfer with surrogate, or we can go ahead with donor FET also. But I think last ISAR it was discussed in one session. Actually, they were telling we have to do only fresh transfers. Is it possible? See, suppose we have many embryos and we have to freeze only. See, getting all these certificates, getting approved.
Yeah, actually, what happens, the initial law is getting changed because of so many practical difficulties. Initially, it was even ART law said that only marital couple with the marriage certificate only can go for ART, and we have been searching the marriage certificate. Then it came even single woman can go for IVF, ART. So the law is little flexible nowadays depending upon our demand. So similarly, right now it is said that storing embryos for the purpose of surrogacy is not acceptable, but similar to oocyte retrieval, we need to retrieve 7 oocytes. These are all gray areas. Up to 55 years, male can donate his sperms. What is the impact of paternal aging? All these are little gray areas in the ART law, but it is getting changed with our demands. So till now, the law says that storing gametes or embryos for surrogacy is not acceptable, but at the same time it doesn't tell that if we have surplus embryos, what do we do? Are we going to discard all those embryos, or can we go for second time IVF, that too with different surrogate or same surrogate? Because surrogate can go for this procedure only once in her lifetime. That means is it not allowed? Sometimes if they go to court gives them some permission. For example, I had one patient, the male came to me at the age of somewhere around 60. Obviously, it is ART is not allowed for that couple, but he had lost his son in an accident almost 1 year back, and he wanted to go for IVF with his sperms and donor egg. He had gone to court and got permission for IVF also. In special circumstances, court also gives permission for them. So till now the law is little it is very unclear whether to go for frozen embryos with the same surrogate or different surrogate is a debatable thing, and it has to be individualized. You are muted. Muted you are. Pungodai madam, you are muted.
Sorry. If the surrogate doesn't conceive in the first fresh transfer, then what to do? Actually, the validity period is only for 1 year. So if we have surplus embryos, for the same surrogate, we can do for the second time. But the whole process she can undergo only once in a lifetime. The law says like that. But is it possible to follow all these?
but it is not very clear. That's what many areas are not very clear for the. Initially, we had doubts about retrieval. We were little hesitant to go for donor oocyte program at all because the law said that from ART bank we need to get from ART bank, which doesn't
Yes.
have any OT setup or even gynecologist, only a registered medical practitioner and few equipments related to IUI is there in bank. How can a bank retrieve oocytes? So there was a dilemma and a few were little hesitant. Even I was hesitant to go for donor oocyte program when the law was implemented for 1 or 2 years. So then it became very clear that bank cannot retrieve oocytes, only clinician can do that. So maybe in the future we'll get a clear idea. Till now it is not very clear, but it says only once and no frozen embryos or gametes is allowed yeah, for the purpose of surrogacy. So let us wait, and if we have any individual case, we can go to we can request our intending couple or intending woman to go to court, get permission,
Court,
and then we
yes.
can go ahead with the.
Yeah. It was a wonderful presentation. Good.
Any
Can I
doubts
say
they can put in the
something?
chat box and Kalpana and Pungoday madam can answer. Any doubts can be posted in the chat box. Vani Pujari, you wanted to say something?
Recently, I've heard that we can transfer up to 3 times. If she is negative, like Pungoday madam was asking whether she becomes negative, whether we can transfer again. We can transfer up to 3 times. That's what we heard. Like we also had a patient,
But
and
there
then
is
she
no
declared
proper
negative.
documentation
Yes,
from
yes. Each,
yeah.
I know there are so many amendments.
Unless
So
we
we
get
asked
proper,
somebody.
even this question answer thing was not considered as a law. That was legal person's argument. That cannot be considered as regulation, and it is just an answer from the board, national board, for our questions. So till now, there is no proper documentation that we can go for 3 transfers. Yes, we can go if
We had a patient who didn't conceive, so we asked few people and then tried to get some information. So they said we can go up to 3 times, so we could go ahead and transfer. But getting the permission is
it's not an easy job.
almost
It
Very
is
difficult. Very difficult.
Yes,
Yes,
years
the
ever
JP
we have.
of
1
the
year at
appropriate
least.
authority tells that they can go for 3 transfers.
Yeah,
And if
3
they
transfers.
want extension, for example, the patient didn't develop endometrium or the surrogate got sick and you want an extension 1 month before, we can even apply for extension for 6 months so that duration can be expanded.
Now the board is very active. Every district has got a surrogacy board, and it is if they give any permission in written, we are in the safe position, whatever it is.
Okay, thank you, thank you. Radhika, are you there?
Yes, ma'am.
Thank you, Kalpana, for the
Thank you,
wonderful
ma'am.
talk. Thank you, Pungoday madam.
Thank you.
Yes, ma'am. So the next.
Radhika can introduce that panel. We'll go to the third session, the panel on IUI. Yes, Radhika.
That was a very nice discussion. Thank you, Kalpana ma'am. So we'll move on to the panel discussion.
Yes, we
Can
will go. Yes, you introduce the moderator, Dr. Vani Pujari and Dr.
Yes,
Aruna
ma'am.
Ashoka.
Yeah, I invite Dr. Vani Pujari ma'am, who is the director Akshaya Fertility Center and Women's Care, and she is the president of Salem chapter of Tapisar and joint treasurer Tapisar and fertility specialist and laparoscopic surgeon. Welcome, ma'am. And I invite Dr. Aruna Ashok, who is the fertility consultant and clinical director, A4 Fertility Center and Hospital. She has 17 years of experience and she is the mentor for fellowship reproductive medicine in A4 Fertility Center from 2022 onwards. And
That's
she's
enough, I
also the
think.
faculty of
Thank you, Dr. Radhika.
reproductive medicine.
Thank you.
Thank you,
Yes.
ma'am.
Thank you,
Oh.
Sampath Kumari madam and organizing team for giving us this opportunity to talk on the topic. And I think I can introduce the panelist. Dr. Dalia is a very well-known fertility specialist in Tirunelveli with academic interest. So she's a consultant reproductive medicine and fertility endoscopy, managing director of Queen's Fertility Center. She has received AL Mudaliar Award. She's a member of many, thank you, member of many societies. And we have Purnima Saravanan, who's a consultant and director of Sri Abhirami Fertility.
Thank you, ma'am.
Erode and Karur. Yes.
Thank you so much, ma'am.
Thank you. Nice.
உன்னை பார்த்து என்ன இப்படி பயப்படுறாங்க? என்ன மாட்டி வச்சிருக்க panelist-ஆ?
They all wanted to be entering into the subject fast. So Madhumita Shekharan is from MCH Reproductive Medicine from SRMC, and she is a fertility specialist from
Thank you, ma'am.
Birthright Fertility by Rainbow
Thank you,
Hospital.
ma'am. Thank you, ma'am.
Thank you. Nice. Yes. And we have Dr. Priyadarshini. She's a managing director and senior consultant in Varam Super Speciality Hospital and Fertility Center, Hosur. Nice. Welcome, Dr. Priyadarshini. And Dr. Vidya Lakshmi. She is for consultant gynecologist, fertility specialist, Excella Gynac Care, Women's Specialty Center, Coimbatore. Madam has covered all the states of Tamil Nadu, I think. Yes, madam. So we have Aarti Sumaida. We very well know her. She is from Sri Siva Hospital and Vamsam Fertility Center. Welcome, Dr. Aarti. Yes. Yes, so myself and Dr. Vani, madam, is going to moderate the session. So we are going to talk on the very basic topic, but yet not conquered to the fullest. That is IUI. I will share this screen. Let me know whether it is seen or not. It is in the slideshow mode. Can you see the slides?
Yes, ma'am. Yes, ma'am.
Yes. So I think one by one, the panelists can take over and then answer the questions in their own way. We want practical points for the viewers to obtain. So how much is this IUI success rate in your centers? Highest and the lowest, you can tell. Very difficult question to answer. Anyone, please.
Lowest is 5%, ma'am. Highest is 26. We have achieved 26.
16%, 16, 18%.
15% on average. So over the years, it has been remaining the same. That is the important point. Whatever chambers we use, whatever centrifuge we use, whatever improvement we have done, we have improved not much in IUI success rates. It's still 15 on an average. We can go up to 25 or cumulative. I'm not asking the cumulative success rate, per month success rate. Cumulative success rate per patient might range from 30 to 40 also. So that is for the 3 IUI cycles. So we have worked hard on this, but still we are not getting good results. So first we'll go for the patient selection. Madhumita, so
Yes, ma'am.
what is the best patient that you want according to the cause of fertility?
According to the cause of fertility. Okay, I'm ovulatory infertility with average age of between 25 to 30 and married life of 3 years and been trying actively with suboptimal or mild
7 is good. You want a
Siemens.
patient with all good and except for
Yes.
the ovulation
Yes.
disorder. So
Yes.
very good. So this is a very well-known topic, so I will skip that. So age of the female partner, up to what age you want to do IUI, or whatever age you will at least counsel them negative after this age on IUI. What is the
I
age?
think up to 35, we can give IUI, again individualized depending upon the AMH and other male factor, the semen parameters.
At
But
least
beyond
after
35,
35,
I think we should execute immense caution.
Good, well told. So one of the important factor is age. So over certain age, at least we should negatively counsel them. And it is not that we don't avoid doing it, we still do it, but negatively counsel them. So age is a very important parameter, there is no doubt. Regarding AMH, is there a cutoff that you will tell to the patient or tell them that below this, it is very difficult, you have to be faster?
No, we take it as
One of you.
1.2, less 1.2. That is what.
Okay. So a married female coming at, say, 28 years, 1.2, 38 years, 1.2. what you will do?
We'll do for 28.
Younger one with 1.2 has a better success rate.
So you
I mean,
try IUI and you will go for normal cycle or IUI and then right?
a natural cycle. Yeah.
So when the AMH is low, the success rate is low, even in different age groups. So AMH is also an important parameter that we have to consider when we are analyzing the success rates. So that's the only point. So age is the number one. By cause, you can tell what all patients are good and what all patients are bad. Vani, madam, you can also.
Yeah.
Good.
Young
I
patient.
mean, you started off saying that we are trying our best, and then we are using all these things, and then somehow we are stuck between these numbers for our success rate. I'm just asking. I'm going to ask a practical question. My concern is, in general, we keep seeing in our practice, iatrogenically, we can do so many things wrong to get a low success rate in IUI. Do you guys agree?
Yes, ma'am.
Iatrogenically. Yes, ma'am. Yes, ma'am.
So we are doing so much to, we say that we have improved this, we have improved that, and Dalia gave, it's not Dalia, Nitya gave us such a beautiful presentation on, if you guys were there, and how to monitor follicle and how to exactly time the IUI and all those things. But can one or two of you give us a few points where we are going wrong? We can go wrong, terribly wrong, and then get our success rate very, very low by ourselves.
In one scenario, that is like giving trigger earlier before even seeing the follicle Doppler changes. Hurriedly saying like mature follicle, like more than 18
Yes.
mm,
Yeah,
we
so
give
17
trigger.
mm routinely, even if they are on clomiphene or letrozole,
Yes.
17 mm is taken as some magic number and given. Very good point. Any other point?
Unexpected cervical stenosis or unexpected problem in semen collection, all those also affect our,
Yeah, all of you are, I think, in the metro cities, probably are not facing this problem. When you get the patients, they have already done IUIs 4 times or 6 times like that. So when you are taking the history as to, you have a patient who is done 4 times IUI. So will you directly go for an IVF, or do you look at how the IUI was done? And if you look at it, and what all points you look at?
Mama, I'll see how frequently.
Basically, we'll see the follicular scan monitoring, ma'am, whether it is been properly done. So because some they do directly at their day 12 or day 13 without even follicular monitoring. So whether they had monitored properly, first we have to see, ma'am, at what point of thing, what trigger they had given, and what is the proper endometrial lining, whether they had followed, and the semen analysis report, pre-wash count, post-wash count, all those things, whether they had followed, we have to monitor.
Proper semen analysis was done, whether proper preparation was done, where was the preparation done, and where was the IUI done. Still, even though our law says
Time of the semen preparation and insemination.
Yes. You guys see that, right? Happening. Even though, according to law, can we do that? According to law, the preparation and insemination has to be.
It has to happen in the same premises.
And there has to be a dedicated lab and an andro technician who has to do a proper preparation. If we don't do proper preparation, and if we do preparation a few kilometers away, and then the patient carries in his pocket, it is still happening. It was happening before the law came in, but it is happening still. So it comes to the OPD, and OPD, we are very busy because we have 10 patients waiting, and then she'll wait, and then the semen sample will wait. So there are so many ways which we can go wrong. If we correct all that, we can match the success rate of Aruna Ashok. I'm sure she's having a success rate of more than 30%.
No, madam.
So I just wanted to
dip up and down, but over the years, I think we should be able to troubleshoot what went wrong that month, why that month success rate reduced.
Yes.
That
Yeah.
much
So
is the expectation
yeah,
from us, that what went wrong, that we should be able to find out. And when the success rate
yes.
is high, what went right in that cycle to get a good success rate? That much is very important, because that's more
So
important.
in a fertility center, we are dedicated to it, and then we go through all the parameters, and then we do this thing. But level one clinics, there are so many things which can go wrong. So if we can, doing a proper stimulation and doing a proper monitoring and waiting for the follicle to mature and give a proper trigger, and then time the trigger, time the insemination, and do a proper semen analysis, proper preparation. If we can do these basics correct, we'll get a reasonably good success rate.
Yes. So the points is, if we have a very good profile, for example, 1 month, you have a patient, all patients with unexplained infertility, mild male factor, anovulatory, that month your success rate might be very high. The other month, you have a patient with low variant reserve, unilateral tubal block, endometriosis, and long-standing subfertility is a major chunk of patients. That month, the success rate might go low. So this much of understanding based on the cost definitely has an important factor. I think everybody believes that. Age is one important factor. Next is AMH, and the next is cause of infertility. So these things has to be documented so that we analyze and then think about it. So this is what is the thing. So the studies have proven that ovulation factor and unexplained infertility has the highest success rate. If you're blessed to have all these patients on a month, my success rate might reach up to 25% or 30% also. So this is how we can analyze our success rate. Maybe at the end of a year, you can analyze how these success rates are there in your center according to the cause of fertility. So this Zip et al. Study is one important study which I've quoted in many of the next presentations. From 2022, they've done a meta-analysis. They've taken lots of parameters, and out of the parameters, like all these parameters, as Madam has told, good ultrasound guidance. Do we do scratching before month? Does the stimulation matter or not? Does the luteal phase matters or not? Does hydrotubation matters or not? What is the trigger? Where is the bed rest to have a role or not? Single or double IUI and trigger. All these parameters they have checked, and they have come to some conclusion at the end of the analysis that only we cannot have so many parameters. If we have so many parameters, we'll not follow anything. So 4 or 5 parameters, which is very useful for our clinical practice. Okay, let me check these 4 parameters, then I know why my success rate went low or high. That's what we are finding
Can we ask our panelists, you've been practicing IUI for several years, and what is that you have done in your practice? What are the extra you are doing to get a good success rate?
Ultrasound guided procedure, ma'am. Because
Who
we
is
have
saying?
Madhumita.
Madhumita. Okay, Dalia, what is that extra you're doing in your
mostly with the full bladder to avoid the difficulty in IUI. The acute anti-motion can be corrected.
Routinely you put a full bladder and
I
go
had
for ultrasound guided.
Negative. Ultrasound guided, sometimes I not routinely, ma'am. If it was a very difficult one, the previous difficulty, then I go for a ultrasound guided. Otherwise, mostly I follow the full bladder IUIs.
One more point, madam.
Aarti is there. Dr. Aarti
Yes,
and Dr.
ma'am. One more
Vidya.
point is, usually after starting IUI, the patient, they'll start abstinence. So we have to instruct them to stay in contact also. So on the day of trigger, usually we'll ask them to stay in contact. That also will help.
Super.
Okay, on the day of the trigger, they can be in contact, and after we finish the procedure also, they can be in.
Very low samples, prefer to do a double IUI also, ma'am. If it is a
So, Dr. Vidya, when will you suggest a double IUI? Would you
For
suggest a double
evidence, there
IUI?
is no real recommendation for a double IUI stating it is better than a single IUI. But in patients where sexual dysfunction is common, where they are not able to have intercourse even post IUI, in such cases, a double IUI, people going for donor insemination for certain indications, maybe double IUI might be of help.
Yeah. One more point I may add. you can, okay. Those two, I think, sexual dysfunction and donor IUI are the valid indication. Sometimes this monitoring, if it is not done properly and you don't know when it is going to rupture and all those things, that probably not a very great indication, but it could be one of the indications to have, because when you are not able to time it properly, so you can do that. So they are the indications for WI. Bed rest after IUI, anybody does?
Yes, ma'am. Bed rest 15 minutes, ma'am. 15 minutes after IUI. Usually we need probably, and sometimes head low position also, ma'am. Bed rest after IUI. Usually I follow, ma'am.
Okay. So preparation to the semen collection to IUI, do you have a timeline in your centers, or
Maximum.
do you follow any timeline? Dalia?
Yeah, from collection to insemination, stick to less than 90 minutes, ma'am. The after viscosity preparation, insemination should be within 60 maximum or 90, ma'am. That is what we follow here.
Anybody else everybody has the same timelines or any other timelines?
We follow the same.
We follow the same.
So that is all of you are IVF specialists, no? That is not happening in the periphery. That's what I was going to say. It could be anywhere between 3 hours, 4 hours, like that. So that is why whatever success rate IUI is supposed to give, that is not happening. So it is very important to maintain these timelines, and we should have a good. Preparation techniques. Do you have any special preparation techniques? So Dr. Vidya.
Myself, I am using density gradient method for most of my patients, and but as per the recommendations say, no particular method of preparation is superior to the other. We can either go with simple washing, swim up, or a density gradient method. But since the very beginning, I've been using density gradient for semen preparation in my IUI cases, so I've been sticking to that because I'm comfortable with the results.
Purnima, what preparations do you use?
Yeah, we follow density gradient, ma'am. And if the counts are good, sometimes we do swim up also.
Okay. So anybody is using the advanced methods? There is some gadgets, no, which are available now.
Microfluidics.
So
that is
using,
No, ma'am. I'm not using.
for IVF only, ma'am.
Aruna is using?
Yes, madam. Max, Zymot and Max, especially for the DFI is high.
Yeah.
And if they're coming for the third cycle, we can offer Zymot for them, especially when the husband is more than 40 years, diabetic, or the sample is good, but since they have not conceived, we can use Zymot. Zymot is the trade name. You can use microfluidics, whichever company you are using. Yeah. So we will, madam, you can ask the team on stimulation protocols also, because next to stimulation, what you're giving, that's most important.
Yeah. So that is very, very important, and very means everybody would want to know. What is your opinion, like Aarti, which drugs do you use commonly for which people, which profile?
Again, we individualize the protocol, madam. Usually, but since IUI is a cost-effective thing, usually we start with oral ovulagens, and then we'll add on some gonadotrophins. It depends on the patient. Sometimes we add RFSH, but mostly in our setup, we use regular gonadotrophin, menotrophins. And for example, we start from day 2 to day 3. We can choose letrozole or clomiphene citrate. In PCOS, preferred one is letrozole, but clomiphene citrate is equally good in unexplained and all. See, in unexplained, already the patient is ovulating, so no point in giving a monofollicular development. So we can go for clomiphene citrate in case of unexplained infertility and all. And then injections, we usually call them back on day 8. We see the response on day 8, and then we add on gonadotrophins, say for example 75 international units for 2 to 3 doses, and then we call them back. We do a proper monitoring follicular study, and other adjuvants
Go for
Again, depends
other.
on the patient. If it's a PCOS patient, myonistal, metformin will help in avoiding overstimulation and all.
Dahlia, is that what you follow, or you start gonadotropins from day 2, or you prefer gonadotropins oral ovulagens, or what's your practice?
Ovulation induction cycles done outside and come here, then I straight away go with gonadotropins, ma'am. Or the reserve is low or age more than 35 years, I always go with gonadotropins. Otherwise, a young and ovulatory female fresh start, you go prefer to go with oral ovulagens. If it is a super ovulation, you are trying to attempt to get more number of follicles in case of unexplained or endometriosis. That way, I go with gonadotropins.
And Dr. Purnima, what is your practice? Which gonadotropins do you use?
Depending on the couple, ma'am, if the ovarian reserve is low, I try to go for FSH, otherwise it will be HMG. Ma'am. We also calculate as per the cost effectiveness also.
If ovarian reserve is less, you go for FSH. Is that what you said?
Yes, ma'am. I go for combined one. Combined one. I start with around day 7 to day 8. I go with HMG. We follow up the follicles, and if it is growing, only HMG will be used, ma'am. In case if in the first cycle, if there is no proper response with HMG, in the next cycle we will start with the combination.
Okay, Dr. Priyadarshini, would you like to add?
Yes, ma'am. Usually oral ovulagens, ma'am. So if I used to follow up on day 8, if the response is low, then we'll add on gonadotropin 75 international units, ma'am.
Okay, oral ovulagens, clomiphene, what is the usual dose all of you use?
50 mg.
We use 100 mg.
I use 50 mg.
50 only, ma'am. The BMI is very high, then I go for 100. Otherwise, 50 only.
50 only. If okay, you give 50 mg for 5 days, and then you call her back on
day 8.
Day 5 or 6, ma'am. We start on day 2 or day 3. We give for 5 days, and we call up back on day 7 or day 8, ma'am.
Okay. If there is no response, what will you do? You're given for clomiphene for 50 milligrams you have given, and you called her back after the 5 days is over. Then there is no dominant follicle. What do you expect? Where should the follicles be?
We expect generally around 10 mm. We expect the follicle to be around 10 to 12 mm on day 6 or day 7 after the oral ovulations. And we follow up with the HMG 75 to 150 depending on the reserve and the follicular count, and either it is a monofollicular development or a multifollicular development, and then we decide on the dose as per the BMI, and then we call up again after 2 days. And we start the estrobed for endometrial lining.
In case of a suspicion of...
you want to say something? Somebody started, please.
Yes, madam. Madhumita here.
Madhu.
Ma'am, in case of suspicion that patient is an ovulatory and there are higher risk of hyperresponse, or that risk is there, when we are starting clomiphene and 5 days, and we are asking the patient to come, if the follicle hasn't grown, and I mean not more than 10 mm, still it's the same size, and we have to wait or still wait for 5 more days before we amp up the dose of clomiphene, or combine even gonadotropin, because of high risk of multiple follicle being developed, and there can be risk of oocysts even with the CC cycles.
Yes. The thing is,
I lost the
right now,
hello. Yeah.
we are sorry.
Sorry, I lost the connection. Sorry, I'm back again.
Okay.
Yeah.
No problem. We are still stimulating. We are still
Yeah,
stimulating.
please. This is the most important topic.
No, actually, when we are stimulating anybody for IUI, we have 2 broad categories. One, she's forming an egg on her own, but she is not conceiving. Okay. This is unexplained infertility. So we are trying to get more eggs for her, so that we are at a better chance of getting at least one euploid embryo. Usually people keep saying 3 eggs. So that means less than 35. The mathematics is in IVF also, if we have at least 3 eggs, we might get a one good euploid embryo. So the same mathematics, the same formula is followed here, and we want to get 3 eggs. Even though she is forming 1 egg, we want to get 3 eggs. So we give either clomiphene or we give either or letrozole to get that number, and we give this and then call her back and then see, and if the follicular growth is at 12 mm, 13 mm, 14 mm, we don't know whether it is going to go ahead and grow on its own, because whatever we have to give, we have given and finished. That stimulation is over. So either we have to continue the stimulation with the gonadotrophins, or just wait and watch whether this 13 mm will go into 19 and 20 mm. So we can try one cycle to see how she responds to 50 milligrams of clomiphene or 100 milligrams of clomiphene. See if she grows her own follicles to 2 or 3 follicles to 17, 18 mm. So you can just check out one cycle and then do an IUI in the second cycle as well. You don't have to add. But in the first cycle, if she's growing 2 follicles or 3 follicles up to 13 mm, and after that they're not growing properly, then we know that we have to give her gonadotrophin. And then as soon as her oral ovulation dose is finished, we'll start our gonadotrophin. If we have given already a larger dose of oral ovulation, it would be prudent to start a larger dose of. Larger means, I'm not saying 200, 300, at least 150. Probably 75 may not grow your 3 follicles, so 150 of HMG might do, because this oral ovulation will increase your both FSH and LH, and we need to continue that stimulation. So that is one category. The other category where she is not forming her own follicle. So we want to induce follicles that we have done already and then given a trimmed intercourse, but she's not got pregnant. So we want little bit more follicles, induce and more follicles. So we are doing the induction also, and we are going to super ovulate also. So that we have to be very, very careful, because if she's forming an egg on her own, if we give a gonadotrophin of lower dosage, or alternate days, or all kinds permutations, combinations are used, FSH, HMG, everything can be okay, because she also has some hormones going on and she's also doing something. But if we are doing all the job of using the follicle and growing the follicle, then we have to be very careful, like when we start, what dose we start, whether we add gonadotrophins from the beginning or add gonadotrophins as soon as oral ovulations are over. And then we have to continue and give the support to that follicle till the follicle reaches 17, or not the 17. If we have used oral ovulation, maybe we'll go up to 20, 21. And then if we are doing Doppler monitorings, then that gives us a really good edge to detect the maturity of the follicle. So these are the two major categories, I think. Yeah, somebody's saying something. You said something?
Yes, madam. I think the overall everybody has given their opinion. So
Yeah.
I think you have concised it, and we go to the next topic.
Yeah.
So for thin endometrium, in an IUI cycle, first we'll start with endometrial preparations. What is that you will do for thin endometrium in your cycle? Doctor, anybody can answer.
Estrogen.
We can add external estradiol valerate 2 milligrams VD or TDS can be added once the follicle has reached a certain dominant stage, beyond which adding external estrogen will not be a problem. We can give supplements like L-arginine to improve the vascularity. Sildenafil 50 milligram vaginal capsule can be supplemented again to enhance the vascularity and endometrial development.
So what is the first priority that you have when you have a thin endometrium? Follicle is 14 millimeters, endometrium is 5 millimeter. What will you do for that patient?
Start on estrogen.
We can start estradiol.
14 mm only follicle, so we can still
We can
wait.
allow the follicle to grow further and check if the endometrium has reached expected thickness.
Look at the stimulation protocol. If it is clomiphene, then you add estrogen. If it is letrozole, we can wait. Sometimes you get a thin endometrium first, and then after 3 or 4 days, you are getting the good endometrium, and the follicle is more than 16 to 17 mm. Only if it is clomiphene, I add estrogen. Erythrozyme means I wait for.
Yes, beautifully told. So I think we can wait. If it is a clomiphene citrate cycle, you can add, but for that also you can wait till 16. And then if you add, most of the time it will be all right, that the endometrium becomes better. And the non-hormonal adjuvants are still there. As she told, aspirin or vitamin E or sildenafil all can improve the endometrial thickness, which can be added even if the previous cycle is thinner, you can add. Do you cancel a cycle because the endometrium is thin? The endometrium after estrogen also is only 6, but the follicle is 20. What will you do?
Most of them go for a luteinized unruptured follicle in these cases. I've seen a lot of luff in these cases. Very big follicle. Mostly they turn out to be a cyst when the endometrium is very thin.
Okay, that you're telling actually it is indirectly the other way. The follicle is good enough to produce estrogen, so the endometrium is thin, and the follicle goes for a luteinized unruptured. Is it like that?
Problem with the oocyte, I feel.
Oocyte is the endometrium is not getting better.
Yeah.
So
We
will
can
you
check the
I'm
estrogen
not
level,
asking you.
ma'am.
Will you do IUI or not?
We'll proceed with no endometrium is thin, ma'am, in case of IUI. We shouldn't cancel IUI cycle considering only the endometrial thickness.
Yes. So endometrium, whatever it is, even at 6 millimeters, when you give a trigger and then see her, we have patients who have conceived. But maybe in the next cycle, you have to rule out tubal infection or in other factors. Whether it is a suboptimal oocyte, as Dr. Dalia has told, if it is a suboptimal oocyte producing less estrogen, or it is an endocrine, it is an endometrial injury or endometritis which is causing thin endometrium, I think you can find out whether it is ovarian factor or an endometrial factor, and depending on the cause, you will treat the patient. And what is the insemination timing that you follow in your centers? When is the trigger you give? When is the IUI that you do? You do a particular pattern or you do it? How you do it?
If the dominant follicle is less than 18 mm, we'll give the trigger injection, ma'am. So after 24 to 48 hours between, we'll do the IUI, ma'am. 24 to 40 hours.
24 to 40 hours. So if the follicle is not ruptured,
hours, no? What
what you will do?
36 to 40 hours is the timing.
Any other parameter that you see and then tell that this is
Nowadays,
the time?
I'm combined with LH search, madam. We can just do a urinary LH kit also. If the LH kit is positive, maybe in 24 hours itself, we can call the patient for IUI. Or if the LH is negative, you can give the trigger and you can call her back after 36 hours.
I see Doppler changes also, ma'am.
Yes.
We can apply Doppler changes.
Yeah. The Doppler is one,
secondary-
I think, which is very easy and simple, handy to follow. Madam, Vani, madam, what do you follow?
No. Me. No, I was going to ask whether you look for rupture and then do the IUI. Everybody.
Yes, definitely,
Or
ma'am.
do a
On the day
fixed-
of the IUI, we check for the rupture and then do the IUI.
So if it is not
ruptured,
well, when will you call her? You have given a trigger. You have given a trigger based on the size of the follicle, right?
Yes.
Or do you see LH, serum LH, urinary LH, and do you see the vascularity or the PSV and RI of the follicle? So what do you see, Dr. Vidya, before you decide to give a trigger?
Perifollicular
Is the
blood flow
size.
is more than 75%, and when the endometrial thickness is good enough, when the follicle has reached a good size of 18 to 20 millimeters, then I plan the trigger, madam.
You give the trigger, and when will you call for a rupture?
Generally,
check?
34 to 36 hours. I ask the patient to come for the IUI, and on the day of the IUI, before the husband gives the sample, I check for the rupture.
So if it is not ruptured, what will you do? What
We
is
can
the
repeat
trigger?
the trigger. We can repeat another trigger, call her the day after, ma'am.
Dr. Dalia, what will you do?
If she has had previous good all ruptured cycles, then I would like to do an IUI and next day look for the rupture, and if it is ruptured, double IUI. Previously, she is a repetitive case of unruptured follicles, then I withhold the IUI, ma'am.
Dr. Aarti, do you do anything different?
Ma'am, usually sometimes the follicle might rupture and it can close back. So if the other parameters were correct, if you are very sure about the RAPSV and we are sure about our timing of the trigger, I think we can proceed with IUI, ma'am. No need to alarm the patient, it's not ruptured.
We can call her back for a check scan the next day.
Next day, yes, ma'am.
For rupture.
Yes.
Yeah, so generally it is probably not a. Dr. Arna, do you give a repeat trigger?
Yes, sometimes we give it
Peptide.
another type of trigger, that is decapeptide, when the LH is also not positive. We see the card and the LH has not become positive, then we give a decapeptide. Not only for the trigger, it also helps in luteal phase support, a dual function. So that is only happening when there is a third cycle. Generally, no trigger additional. One HCG given. Most of the time, if they don't rupture 36 hours, they rupture by 48 hours. Before 48 hours, they rupture. So I don't, as Dr. Vani was telling, we are not seeing lupinus and rupture very commonly. It is only 1 to 2% of patients. But mostly, as Dr. Aarti told, it is reseals. Resealing is one. And then delayed rupture. It ruptures by evening. We see in the morning, it ruptures in the evening. And these two are the most common. What we did was, we called the patient on 7th day. That time also, when you see a corpus luteum with a good blood flow, it indicates that the follicle is ruptured. And the number of patients who are brought positive after on the day of IUI, if it is ruptured or not ruptured, is almost equal. The success rate is same.
Yes, yes.
So it doesn't matter. Yeah.
Yeah. And how long is the oocyte alive or has the fertilization capacity after it is released?
Maximum fertility
24 hours. Maximum is up to 24 hours.
Highest in 24
to
hours. No?
16 hours, it can be alive in the tube once it is released. Once there is LH surge, oocyte can be released between 24 to 48 hours. Anytime between 24 to 48 hours after the LH surge. Once it is released, it is 12 to 16 hours. I mean, correct me if I'm wrong. It's from the books only. So 12 means to calculate all this. And once we put the sperms in, because when we are doing the semen preparation, the sperms are activated, right?
Yes. Yes,
Sperms are activated. So they can work for how many hours?
2 to 3 hours.
Yes, 3 hours. So oocyte will be there for 12 to 16 hours. Sperms will work only for 3 hours. So little bit later IUI, there are a lot of people who follow 40-hour IUI. Give the trigger and do 40 hours. If you are doing single IUI, means a single thing. Because even if we look for rupture, we are not very sure whether it is ruptured or not ruptured. Half the time we are not sure. Most of the time it would have ruptured. If you think it is not ruptured and call her back after 5 days, like Dr. Arna said, you will see a good corpus luteum. That means it has ruptured, right? So it is better to do, if you have given a good trigger, it is better to go ahead and do an IUI. And
Sorry.
yeah, Dr. Arna, you think?
Yeah, I think the screen sharing is still there. Sorry, the screen
So
sharing.
that is the logic for a lot of people doing IUI at around 40 hours, because even if it has released around 30 or 30, it is still there. It is still there and available for fertilization, because the sperms, activated sperms, which we are trying to deliver inside the uterus, they work only for 3 hours. So probably if we are doing one, we can do a bit later on. And trigger, we have to be very, very careful when to give. Yeah, Doctor.
I'm just wondering, it is 3 hours or it is 8 hours? That's the only query I have. But anyway, I will look into literature. Yeah, after capacitation, you're telling that it is only 3 hours that
After
stays
capacitation, at least I am in the belief that it is 3 hours, because I've read somewhere, not that.
I will see, because there was lots of papers that I read whenever the success rate was being, because
yeah,
the
please,
logic of double
I might
information.
be. Yeah, I might
Yeah.
be wrong. It is just I'm telling about what I have learned. But
Yeah.
you know,
I think we all will go back, research, and then come back with the answer on this. Because there is not much of studies on post-capacitation sperms, how much it is going to be helpful, because it's very difficult to study.
It is like it is very early studies when the IUI was trying to come into vogue and trying to establish itself. That is when people were really breaking their heads when to do the IUI and how
I'm
do we
very
time.
happy to hear from a doctor who tells me like this. She has done a research on these parameters. I was thinking we are thinking something different. Why people are not talking about these things? So I'm very happy to hear from you, madam. I'll anyway go back. I vaguely remember it as 8 hours or 12 hours.
This was all.
So I'll get
This
back
was
again.
all gone talk, Karna.
Yes, yes.
Now nobody talks about these things all
No,
because so
whenever
many other things have
we
come
wanted
up.
to improve on the success rates, we go back and read what to do for the patient. And this is the parameters that we don't get data. How long the sperm is going to be active, how frequently we have to do, what is the newer thing that we have to do. And coming back to the trigger day, the Doppler, one of the doctor told me that LS surge is good, it is easier, but you have a hand Doppler and you can do a Doppler for the follicle. If the follicle is having good RI is less and peak systolic velocity is good, then even in 24 hours, the follicle might rupture.
Yes.
The flow is good and that it's 100% flow all over perifollicular Doppler is enhancing. So those patients can be called as 24 hours. And if the Doppler is not very good, even 1 day delay can be done and then you can do IUI. So Doppler in a trigger day, at least we should do. If not on the second day, at least trigger day, we should be doing Doppler. And I think this is what we are following in our center, but I think madam, as she told, 36 to 38 hours is usual time that we see, because 36 hours, if we ask a patient to give sample, by the time it get ready and then we do it is 38 to 40. So this is how it is done. So I think you all have preparation technique we have already spoken and we all want a good preparation. So we also should audit our andrology lab. I don't know how many of you are auditing your andrology lab at least monthly once. We believe in our andrologists, but like an exam which is conducted for students, we also should go and test at least monthly once. Do you anybody practice and how do you test? Very difficult, in our busy practice.
Very difficult. Majority of us go by success rates. If that particular month we are getting less success, we are, oh, why? What's happening? Why are you not getting? Why are you not giving me the same? Whatever. That's what they keep saying, madam. Like you said, no, in the initial, the patient we choose is the most important.
Yes.
The gametes we give, that is the most important thing. So the semen sample we give. So one question I want to ask: when do you not do IUI? Each of you.
Yes.
Where you're not happy doing IUI.
I mean,
On
there are,
female side and male side, you can just tell. Yeah.
if there are
Very,
Yeah, one by one.
very poor semen samples, ma'am. Feel that the post wash will not be that sufficient to get.
Who is talking? I'm not able to see. That's why.
Very poor semen sample is one we should not be doing. And
What,
definitely, I think.
anything else?
Bilateral chamber block.
Without ensuring patent tubes.
More than
Hyperstimulation.
more than 4 follicles.
Yes.
Hyperstimulation. High estrogen.
Advanced stage.
Advanced stage endometriosis, we should not do
Advanced
bilateral
stage,
tubal block.
severe, moderate to severe endometriosis, suspected
Bilateral
tubal
tubal block.
factor.
Tubal.
Yeah. So if a patient is having mild male factor is fine, moderate to severe male factor, if they come and ask you for IUI, do you deny or what would you do? Dr. Aarti.
Try IUI, ma'am.
Depends on the
Explain
female age,
proper
ma'am.
counseling.
We can see the total motile sperm concentration, ma'am.
Yeah.
You can give a chance after proper counseling, ma'am, if they opt for the IUI.
Yeah, there is a recent publication which gives us what count gives what percentage. It is there in Fertility Sterility, I think a couple of 2024 publication, I think. So we can use that, and then because your semen is falling like this and this is your success rate, and then we will expect only this much. So we can counsel them, and then probably, because if we completely deny and they will feel bad that want to try to push them towards IVF. So we can tell them, we can have that table and then tell them that this is what your success rate is, but we are willing to do it as long as you are accepting this much success rate, but we'll not be very happy doing it. And we keep seeing all the time after 40 and she has only 1 follicle and 2 follicles. Would you guys do an IUI still?
After 40.
Maybe if she patient insists, but we will not.
After 40, ma'am.
Yeah, 40. She's 40. 40, married for 1 year. She says, I've tried naturally for 1 year, so now I've come and then probably you can do an
It is
IUI
like,
for me.
it is not a contraindication, but we have to counsel the patient. The
We
success
have
is
to
very good.
counsel the patient that she might lose the existing couple of follicles in the process of IUI, which only offers 10 to 15% success rate in her case. And if she is willing to risk that, we can still go ahead. And we should also at the same time explain that with those 2 follicles, if it happens to be good in IVF, we will have a better success rate for her. So after explaining this, if she is very particular to go ahead only with IUI, then we can proceed.
So
They are not affordable. We might have to go for an IUI only.
I don't know, ma'am. I have one question. Like you asked, no, how do you
I think we are
evaluate
supposed
your?
to ask a question and you cannot ask us a question.
Sorry, ma'am. Only thing you
I'm
stopped
just making fun
explaining
of.
that. I
Please
just
ask
want
the
to.
question. Yeah. Huh?
No, no.
Yeah.
How you were saying about andrology lab scoring, right? Like how do we evaluate? Can you explain that? How do you do it?
It is like how you can do regular audit at least monthly once you have to do. And post-wash motile sperms, there should be 95% of sperms should be motile post-wash. So they've done a good analysis. And you have to time their procedure. Sometimes they keep long waiting time. They have some other thing and they just make the sample wait. So correct auditing of the timeline is very important. QA/QC is one. And post-wash sperms, motile sperm count should be 95%. And if it is not good, post-washing technique is not good. So then the sample will not be correct. So these are the 3 things that we do for auditing the IUI lab. So I think due to lack of time, it is already 6:40 and we are discussing. I think the whole day also we can discuss. But luteal phase support and timing, everything everybody is well versed in that. So I didn't go into the depth. Finally, to see optimizing the IUI outcomes, I thought this scoring table will be useful for everybody to see where we went wrong in this month and where we went high in this month. So you can score this and then score for each patient. If the score is less than 5, then the patient factor itself is bad. So you need not get worried about and you not be bullying the android technologist or your sisters who's not helping you in the correct way or whatever it is. But if the score is good, all the patients have good score and this still your success rate is low, then something has to be done. As Madam has started, Dr. Mani Madam has told, as doctors, what we did wrong. What we did wrong to the patient so that the success rate is not good. So that can be playing a role if the score is better. For example, the age is less, AMH is good, and patient is having only unexplained infertility, sperm count is good. Still, all the patients got failed. Then that's something wrong. The success rate should be at least above 15%. So this is the idea. So this scoring is adapted from the study which I told you already. So I think we are here with a take home. So we have to keep updating IUI, though it is an old method. There are new. We can close the session. Any further discussion anyway for the capacitated sperms? I'm curious. I'll go and read back and then come back, Dr. Vani Madam, and then everybody can take these messages, use in your clinics if you're not following some. So I think it's a nice presentation. Any take home from Dr. Vani?
Yeah, so I always tell a proper workup before we start any procedure or any stimulation or anything. So I just stimulating with letrozole and doing off an IUI in the first cycle even before we assess the couple. So proper assessment of the couple is very important. We should have a diagnosis for the infertility because the unexplained infertility is very, very less now. It is not like 30-40% now. If we keep our minds to it and then do a proper evaluation, unexplained causes for infertility fertility has come down to almost 5%. So if we take a good history and reasonably good investigations, we will have a proper diagnosis. If we have a proper diagnosis, we will automatically be giving a good treatment for them. We'll know whether she's the right candidate for IUI or she's not. So our counseling will be good, and the acceptance rate of the success rate which we are going to offer, that will also be good. So getting a proper diagnosis is extremely important. That's what I would say, which will improve any kind of success in our. What would you say, Aruna?
Yes, definitely, madam. Only when we don't know the questions, we cannot write the answers. So I always feel that we have to have a diagnosis to treat the patient. If we don't have a diagnosis, the treatment is like empirical treatment that we do, and it's not going to work.
Right from the day one, it's empirical. So what are we don't have an expectation. We don't know what to expect. So patients also don't know what to expect.
Yes.
So yeah.
Yes.
Thank you so much, Aruna.
Thank you, madam.
Thank you so much, everybody, and thank you all the panelists, and thank you Sampath ma'am for giving us this wonderful opportunity.
I'm sorry to interrupt, ma'am. Ma'am, maximum number of IUI cycles, ma'am, because patients know here they won't easily get accept for IVF. They'll be asking for more than 3 cycles, more than 6 cycles of IUI. So in that case, the maximum number of IUI cycles which we can follow, ma'am.
6. What I would say is, again, I'll go back to proper workup. And if you have a proper diagnosis, you will know how many cycles you want to do. If you are doing a donor IUI, and if she is young, so you will be expecting a better success rate, but it's okay to go beyond a certain number. A majority would say 3. So if she is beyond 35, so you don't want to go beyond 3 probably. And if she's got moderate endometriosis, so you want to offer IUI as a first line before we go for IVF. So you'll tell her that you have an endometriosis. I don't want to go drag too much. Probably I'll try 2 to 3 cycles, good cycles of IUI, and if you're not conceiving in that, I'll be going for IVF. So once we have a proper diagnosis, we will automatically know how many cycles we would want to try. So we can tell them beforehand, so this is the number of cycles which I'm willing to try for you. And then in that there will be a bargain. Some people will want to push off to IVF very quickly. What you keep on, we have done already one IUI, and then it is, so we have to explain the concept of IUI, and then why we are trying at least 2 to 3, and then in some cases 6, based on the age and based on the male. If it is a severe OAT, we don't want to push, keep on pushing. But still, if they are very young and they want to keep trying and they can't afford an IVF, if the male factor is less, probably we are justified in keep doing it for some more time. So like that, we have to arrive at a number after having a diagnosis and a discussion with them. So we are going to try this many cycles, and if you're not conceiving in that, probably we are looking at. So if we have this conversation before we start our first IUI, then we don't have to face like after first IUI, where is my pregnancy, where is my baby? So you have done an IUI, it failed. They'll say. So it's not a failure. We are on the road to success. We can tell them.
Thank you, ma'am.
Thank you.
Thank you, ma'am. Sorry,
Sorry to interrupt. One more doubt, madam. Aruna, ma'am.
Yeah.
Ma'am, how will you apply Zymot in IUI, ma'am?
There are 2 devices in microfluidics. One is for IVF, which is specifically designed for IVF, and very few sperms can be collected. For
You'll
IUI,
get a
there
very
is a
low
device.
volume in that IVF dish, no, ma'am, that microfluidics.
No. You will get the 0.5 ml. There is a different dish for IUI.
Separate one
Oh,
for
for IUI, it's a different.
Separate one for IUI, separate one for IVF. It is not the same.
Okay.
You can use the
But
IUI one for IVF, but the IVF one cannot be used for IUI.
But it is costly. Only Aruna can afford 5,000.
5,000? But it is even any clinics they can use, no, madam. They need not use density gradient. They can directly use IMOT. When you look
The
at
raw sample we have to put in that.
Raw sample you have to put, and then it gets filtrated. I think in future nobody will buy incubators, centrifuge, and everything. You just use IMOT and then give it. The success rate is proven.
Thank you, ma'am.
Thank you, ma'am.
Thank you.
Thank you very
Thank you,
much.
madam.
Dr. Radhika is there, Sampath Madam is there. So thank you, TNFOG, for giving
Thank
us
you,
the
ma'am.
opportunity. Thank you. Thank you.
Thank you, Arna ma'am.
Thank you.
And that was a great panel discussion. I think Dr. Vidya Gayatri is there. She will give the vote
I'm
of
so
thanks.
sorry I couldn't join. Actually, it is my loss. Got caught in emergency. Thank you so much for the formal vote of thanks. A very special thank you to Sadhana Gupta madam for coming and blessing our program. And all these speakers, chairpersons, panelists, moderators, everyone for putting all your thoughts here and getting what is latest to us. And I thank my coordinator, Dr. Radhika Gauri, and she'll connect for the platform. Thank you, everyone.
Thank you. Thank you so much. We will see you in the next
next marathon.
Yes, thank you.
Thank you, madam. Thank you, Gayatri, madam.
Thank you. Happy New Year to all. Thank you.